This is the James Cancer-Free World podcast. I'm Steve Wartenberg, and this is our final podcast of 2025 and a special episode. 7 highlights from the past year's episodes featuring the amazing world-class scientists, physicians, and administrators of the James who are revolutionizing cancer research and treatment and providing better options for patients here at the James and around the world. So let's get started. Our first clip is from episode 198 with Dr. Roy, a James medical oncologist who specializes in treating patients with breast cancer. She filled us in on lobular breast cancer, a rare form of breast cancer that's hard to detect with traditional screening.
The second most common type of breast cancer is called as lobular breast cancer. And lobular breast cancer is seen in 10 to 15% of the patients. But we need to keep in mind that it's very hard to diagnose lobular breast cancer from the imaging, from the mammogram technique. And this is another space where we utilize the MRI of the breast, even if the patient does not have a high-risk feature. So it's always better to refer the patient to get a bilateral MRI of the breast so that we can identify cancers like lobular breast cancer, which can be missed in the usual mammogram. Because lobular breast cancer does not usually form a lump. When we think about breast cancer, all patients think that it's a lump, right? But lobular breast cancer, it does not have a protein in the cells which actually keeps the cells together. And as that protein is called as E-cadherin. So as the lobular breast cancer cells, it doesn't have the protein to keep them stick together. Instead of forming a mass or a lump, this lobular breast cancer actually forms a file or a sheet. So you won't see a mass in the mammogram. Instead of that, you may be seeing like there is an area of thickness. There is an area of thickness in the breast. Or you may feel like the mammogram looks a little bit cloudier a little bit cloudy when compared to the usual other mammograms.
Our next clip is with Roberto Benzo from episode 197. Roberto is a health promotion and behavioral scientist, and he is the director of the James Lifestyle Lab. Roberto and his team study how behaviors such as diet, exercise, or lack of exercise, weight and obesity, and alcohol consumption can all impact a person's risk of getting cancer and dying from cancer. And they also work with James patients because lifestyle changes, even after a cancer diagnosis, can lead to better outcomes and better quality of life.
We know that 18% of all cancer cases, which is about 1 in 5, are due to our body weight. So if we're healthy weight or overweight or obese, by our physical activity, so how much activity we get every day, and by what we eat and drink, meaning the food that we take in and alcohol. So these 4 things attribute to nearly 1 in 5 cancer cases. And that's important to consider given that nearly 1 in 2 individuals in the world will be diagnosed with some sort of cancer.
And that does not even include smoking, which probably is a huge percentage of cancer cases.
Huge.
So we obviously know smoking, direct link to cancer, but the things you just said, obesity, exercise, eating, that contributes 18% of all cancers.
And 16% of cancer deaths. So even after we get cancer, it's not too late. Often we know that being more active and eating healthier will help tolerate more of the treatment that you're getting, the therapies, will allow you to better manage the symptoms that were very common in the kind of therapies that are for cancer. So at the Lifestyle Lab, the way we get people empowered, right? We often use a lot of wearables, a lot of mobile health technology, which we can come back to. We use a lot of technology in terms of computational models as well to analyze that data. And so that we develop a lot of applications and other kinds of solutions that integrate the data from the wearable so we can process it and empower people to see where they are and what is the next step.
Yeah, that's true, because just knowing how many steps you take in a day may not be the answer to everything.
Right. Maybe it's about the many steps that you get, and because it's not the same every day, and identifying when is it lower, when is it higher? What are the reasons for that?
Pancreatic cancer is hard to detect. Dr. Krishna is a physician scientist who specializes in the early detection of pancreatic cancer, and in episode 186, he described how artificial intelligence combined with the expertise of an experienced James physician is now helping to better detect and map out the growth of pancreatic cancer in patients, which leads to better outcomes.
These images move very fast. It's what I describe as you're almost going at 500 miles per hour, and I want you to count how many black and white and red color cars you see while you're going that fast.
Oh, I see what you mean. Yeah, the faster you go in a car,
you cannot
zoom out. You can't read the sign.
So because this is a tiny probe in a larger cyst, and the patient is constantly breathing, and when the diaphragm moves, the pancreas moves with it, and then the images move very fast. So while for somebody who's been doing this for many years, for a trained eye, they can diagnose this right away.
Like you.
Yeah. And there are quite a few who have been doing this. But if you want this to be widely applicable, then we need help.
I see. So here at the James, you have experts who've read thousands of them, but out in the outside world, there are doctors who just don't have the volume and the experience you have.
Yeah. So because of that, we have been building an AI model. We have like the third version of the AI model now, and we have published a couple of versions before. Essentially, what it does is that this fast video, which is going to read it faster than a human brain, and then it'll give us a diagnosis whether this is low risk or high risk. But from a human point of view, it's not that you have to completely agree with what the AI says. You will do your own homework. You will review the video. But when you're kind of not sure, or if you're kind of not well trained in this, you can trust the AI, and the accuracy of the AI is about 90%, which is pretty good. Even the human accuracy is about 90%, so it kind of matches the human accuracy. And the AI models, they only get better and better with more cases. So over time, it will be fully optimized where you can trust the AI in making a decision. But still, I would say it has to be a combined decision between a trained eye and the AI.
Prostate cancer is the second most common cancer found in men, behind only skin cancer. In episode 178, Dr. Sood, who specializes in treating prostate and bladder cancer, discussed the importance of screening, improvements in treatment, the all-important Gleason scale and what it means, and the concept and fundamentals of active surveillance. Like many other cancers, the earlier you detect and start treating prostate cancer, the better the outcome?
Absolutely. So it is a very kind of nuanced approach, or a very risk-adapted approach that we take. But you're absolutely right that we want to detect cancers early on, so we can either keep a close eye on the cancers. Not all cancers need treatment, but at least detecting it early, keeping an eye on it, and then treating when the time is right is the right thing to do. Most of the guidelines which we follow, such as the NCCN or the AUA guidelines, they recommend that men be screened start screening at age 45 and continue that until 75 years of age. And it's based on very, very good data. So that is a very strong recommendation from us. If you're at high risk, such as some of the things we talked about, such as African American ancestry or strong family history, not just of prostate cancer, but if you have family history of prostate cancer, breast cancer, pancreatic cancer, and some other cancers, they can actually all increase the risk for prostate cancer. There are three things I look at when I make the decision about the treatment for prostate cancer. One is the PSA. Second is the findings from the MRI or digital finger exam. And the third is the biopsy score. And I think the biopsy score is the most important thing, which is the Gleason score. So the Gleason score actually goes from 6 to 10. It's a little bit counterintuitive, because many patients are like, what is 1 to 5? So I always say 1 to 5 is not considered cancer, and it's not reported as such. Now, men who are diagnosed with Gleason 6, we offer them active surveillance. And I want to be clear that active surveillance is a treatment, and the goal of active surveillance is to maximize the quality of life for patients while at the same time preserving their quantity of life. So we are not putting patients at risk that this cancer is going to get worse or spread or anything like that, because we keep a very close eye on different numbers like PSA, doing routine MRIs, and doing biopsies in a timely fashion.
We're going to take a quick break and be back to hear from 3 more James doctors.
The best outcomes for treating cancer come from early detection and early diagnosis.
The James Cancer Diagnostic Center at Ohio State
is designed to provide rapid evaluation and a clear diagnosis.
We are transforming care by giving patients direct access
to cancer experts who study and treat cancer every day.
If you think you have cancer, the choice is clear.
Choose the James Cancer Diagnostic Center.
We're back with our special year-end episode, and up next is something from episode 195 featuring Dr. Pamela Liu, a surgical oncologist and the lead of the James Hyperthermic Intraperitoneal Chemotherapy Team, which is abbreviated as HIPEC, and is an amazing procedure in which heated chemotherapy is injected directly into a patient's cancer during their surgery.
We have a special perfusion machine that both allows the chemotherapy solution to circulate throughout the abdomen, making sure that all the surfaces get contacted with the chemotherapy, and also maintain the temperature, because the H for HIPEC is hyperthermic, so hot chemotherapy. That helps both potentiate the effect of the chemotherapy that has on any residual cancer cells, and also heat itself can also help kill cancer cells.
How hot is the chemotherapy?
So our goal for the chemotherapy solution is about 42 degrees Celsius.
That doesn't sound that hot. Oh, wait, Celsius.
Celsius, yes, exactly.
Ooh, help me. What is that Fahrenheit? That's pretty hot.
That is a great question.
That's like...
It's warm.
Yeah, okay.
But we do also keep a very close eye on our patient's body temperature with the help of our anesthesia colleagues during this time, because we, want our patients to obviously not get too hot. So we take a bunch of measures. The anesthesia teams here are fantastic, and they will do things like use ice, cooling blankets to make sure that the core temperature, so our body temperature in the operating room, is in a slightly elevated but safe zone.
Why is heated chemotherapy better than just whatever room temperature, I guess?
Right. So we know that the heat helps the effect of the chemotherapy when it comes into contact with cancer cells. And also, again, heat alone can have some effect, cytotoxic effects, so helping cancer cells, die. So both of those are why we have the chemotherapy solution heated to that target temperature.
Now, I know there's no such thing as a typical surgery, but in general, it sounds like a complicated surgery. How long can it last from the beginning through the through the cyto and then through the HIPEC?
So it depends, I would say, largely on how much tumor there is in the abdomen. For folks who have a lower range of tumor burden, that part can just take a few hours. For folks who have a really high tumor burden, that can take, 8 to 10 hours just to get all the tumor out.
So one patient a day can be your entire day, and
Yep.
That's an exhausting day.
Yep. But I think when you're in those situations, you kind of lose track of time. You kind of just go through and with the goal of just kind of getting the operation done.
Yeah, that is true. When you're in that zone, in something you love doing, the time does go by quick. The relatively new and fast-growing James Cancer Diagnostic Center has become a tremendous resource for the Central Ohio community. In episode 190, we had 4 of the leaders of the center, and this clip features Dr. Raquel Reinbold, the medical director of the Diagnostic Center, and Tina Sowers, the administrator of the center.
We see all kinds of different things in this clinic. Certainly folks who have kind of unexplained lumps and bumps. We see plenty of patients who maybe went to the emergency department for a particular symptom. They ended up having some kind of imaging done, and it showed kind of an incidental or unexpected finding. And so our team will ingest that and kind of help work through it. We have plenty of referrals from primary care docs. I think a lot of what this clinic does is also outstanding care coordination. And the piece piece of that too is that we work really, really closely with our James specialists, which I can't underscore the importance of that enough. Being able to take sometimes very challenging clinical presentations and say, oh gosh, what do we do next? And having a really multidisciplinary, comprehensive discussion with some of our experts, that's been very helpful too to kind of navigate some of those symptoms.
Yeah, I've always impressed by the expertise of the experts that come on the podcast in every kind of cancer that there is, and you get the people that come into the right people immediately. And I know this might be a tough question, but is there any way you can estimate for us or have numbers about how many people you've seen and what percentage or numbers of those actually have a cancer or cancer-related kind of illness?
Tina, I'll let you take this one.
We have probably, since we opened, we've seen about 7,000 total patients, total visits. About 3,400 of those have been new patients to us.
To the Ohio State Medical.
To the James Diagnostic Clinic. And of those, we have about 40% that end up with some kind of cancer diagnosis.
Wow. And Raquel, is there, this might be hard to answer, but can you categorize the types of cancers you're seeing most commonly? And does it fit in with the types that are most common?
Sure. So we, see plenty of cancers, blood cancers, if you will, or things like I mentioned earlier, things with lumps and bumps and lymph nodes that are enlarged. We also see a fair number of kind of GI cancers as well as lung or thoracic cancers. But quite frankly, one never knows what's going to walk through our clinic. And sometimes too, it's not cancer. While that's certainly a relief, we do our best to at least maybe we don't come up with the diagnosis, but at least to send that patient to kind of maybe the next best place, if that's a different type of expert or having a discussion back with their primary care doc.
Yeah, and as being part of the Ohio State Wexner Medical Center, you have those experts available.
Absolutely.
So we've talked a lot about early diagnosis and why that's important. So I take it that that's sort of the mission of your diagnostic center, to diagnose people early, but just again, fill us in on why that's so important.
You want me to start with this one?
You can start.
All right.
This is Raquel.
Yeah, sure. Well, certainly we see better outcomes. Patients have better quality of life, less treatment toxicities, and we know how important it is, especially in solid tumor cancers, when we have an opportunity to do surgery and remove it and cure patients, that's where we really want to catch folks. So there's so many reasons for that, and that's why we're firm advocates of screening and trying to be aggressive about, not ignoring symptoms and trying to figure things out early when able.
Our final clip is with Samik Roy Chowdhury. In episode 193, Samik filled us in on a groundbreaking new clinical trial he is leading from here at the James. It's the first national telemedicine cancer clinical trial. It's for patients with a rare form of pancreatic cancer with a specific genetic mutation, and this first-of-its-kind trial, which can and will include patients from anywhere in the United States, could lead to more and more telemedicine clinical trials from the James and other leading cancer centers. This will reduce costs, improve access, and give patients with rare cancers more options and more hope.
The first week of the COVID shutdown in March of 2020, I had a new referral for a patient with advanced endometrial cancer, and she had an FGFR mutation, and she was being sent to me for one of our FGFR basket trials, and I got permission
to do it via telemed,
to evaluate the patient and do as much as we could by telehealth. We qualified her as being eligible. We shipped her drug in the mail. Normally you would dispense it in person with a bag of pills or a pill bottle in a bag, but we just shipped it to her. She started treatment, and we eventually saw her for the first time as things changed during the pandemic 6 weeks later. When we met her for the first time ever, we hugged, and we were both grateful that we could move on with the trial. She continued to benefit. Her tumor shrunk she maybe benefited for a little more than 2 years for a disease that was not responding to standard treatments for metastatic uterus cancer. And so that was, 5 years ago. And in the past 5 years, we've had this observation in pancreatic cancer And so now it's time to connect the dots, right? So can we do telemedicine for pancreatic cancer with FGFR, but not just in Ohio? The boundary doesn't have to stop there. It can just be the entire nation. So we're disrupting
administrative
clinical trials. We're disrupting clinical
trials.
trials. We can do things in a better way that's going to be more cost effective and have a wider reach. So instead of thinking about a trial with 50 locations with a $20 million price tag, it still has a limited reach when you're talking about a rare cancer subtype. We now have soil to soil, Atlantic Ocean to Pacific Ocean reach, right? We can go to Hawaii. And we've reduced the cost of the trial from $20 million to $2 million. And I think we're going to move the needle in a big way. Again, when you have a precision oncology target, you're more likely to do well if you can match the patient to that. And I think up until now, our traditional clinical trial approach sort of is a barrier to go after rare targets. And I think overcoming that, I think we're going to see some outcomes where people benefit and people get more time with their loved ones, and we're all going to be better off.
Thank you to everyone for being part of this podcast. And as always, I'm so impressed with not just the technical, surgical, and scientific skills of our guests from the James, but also their passion and commitment to improve treatment options and the quality of life for their James patients. We have a lot planned for 2026, so please stay tuned. The audio version of the James Cancer-Free World podcast is available on Spotify and Apple, and you can watch the video version by subscribing to the OSU-CCC James channel on YouTube. A special thank you to Ken Hines in James Marketing and to our videographer, Dominic Dodrill, for helping to put this episode together. This podcast is brought to you by the Ohio State University Comprehensive Cancer Center, Arthur G. James Cancer Hospital, and Richard J. Solove Research Institute. For more information, check out our website, cancer.osu.edu.